Everybody knows Alsimca. I don't have to review it, but nevertheless, there's some things that I think we can sort of emphasize and be able to move forward from. You know, what we learned and what we did not learn from Alsimca. We learned about some concomitant therapies were absolutely fine. We learned about concomitant external beam being perfectly acceptable. You can just give external beam and keep going with the radium. Bisphosphonates, actually a stratification factor, absolutely safe, and some actually interesting interactions, which I'll show you if you haven't seen them. And any old hormonal agent seemed to work, bicalutamide, dexamethasone, DES. However, there was no ABI, no ENZA, no denosumide, no chemo, and no imaging. So we have a whole lot more to learn, and really no correlative studies either. So let's just look at this as a huge learning opportunity. And it's sort of a blessing that this turned out to be positive. The Alsimca, we managed to get the right dose, the right duration, the right patients, first phase 3, and bingo, it was a winner. So repeat radium, Tanya, I made a reference to that. So here is a provocative slide from the repeat radium in highly selected patients. Note highly selected patients. This is radiographic progression in bone. Now this is measured from the beginning of cycle 7 to the end of treatment, whenever that might be. And by the way, about 2/3 of the patients completed 12 cycles. And what you see is a Kaplan-Meier curve that looks fairly remarkable, because there was one patient out of 44 that had bone progression as measured by a bone scan. Well, that's pretty interesting. And this was also interesting because this is time to radiographic progression as a whole, but this included CAT scans in addition to the bone scan. So I just told you they didn't progress in the bone, so guess where they progressed? It was virtually all the progression was in the soft tissue, which of course makes a lot of sense because radium doesn't go to soft tissue. So we have a little better idea about imaging, but we really have so much more to learn. For instance, we can now image activities with things like FDG PET, choline PET, and we just don't have a lot of experience with radium, but right here, you have a guy with a T-spine that's pretty hot on choline PET before radium, and after radium, that goes away. Well, I don't know how many more patients are like this. This is an anecdote, not a study, but I think there's a lot more that we need to learn. And by the way, we need to go ahead, and Chris Logothetis is doing this, is getting a lot of bone marrows on these patients to look more at the microenvironment and more. Well, Ken Pienta, one of my favorite guys who's not here, introduced, I think, a long time ago. I can't remember when Ken first sent me this slide, but it really was about the microenvironment in a structured way with osteoclast, osteoblast, extracellular matrix, tumor cell, immune cells, endothelial, stromal cells, all interacting. You know, this is like what we call the host. John, I think you got it here. There's a certain element of the host that plays a pretty important role in our interactions. And now we begin to think about how can we target these various components. And there are lots of components that we could target. So one element of the stroma that we can manipulate is actually the osteoclast. And we can do this with bisphosphonates. And a lot of people don't really think about bisphosphonates as being stromal modifying agents that can alter the uptake of an isotope, but you should know absolutely positively that technetium 99-MDP, our typical bone scan, goes to precisely the same target that radium does. So if you want to know where radium is going to go, just do a bone scan and you're going to see. And right here you can see before bisphosphonates, you don't have a lot of uptake, and after bisphosphonates, you do. And this was a relatively naked study, so you have an induction of the radium target. Well, that actually might make radium bind a little better, and it makes sense. You're cutting down on the osteolytic activity, osteoblastic activity in terms of ratio is going to go up. Radium gets a better target. So over the consequence of this, what we stratified in the Alsimca trial with regard to the use of bisphosphonates, by the way, when I talk about bisphosphonates here, it's about 80+% zoledronic acid. There were a few other bisphosphonates used, but it's mainly zoledronic acid. And what you can see, I can't point on both sides, but in terms of the SSEs, there was really a quite dramatic effect with a hazard ratio of 0.49, lots of p-values, dramatic effect in terms of the combination. Now, you still had a benefit in terms of SSEs with radium without bisphosphonates, but clearly you can see that there was more benefit, but there was no benefit in terms of survival. We looked at survival, and the use of bisphosphonates did not change survival. But now we have a non-randomized, and I'll just go quickly into the expanded access. These were the patients post-approval, but post-Alcemca, but pre-approval, who were enabled through by our programs to be able to get access to radium. And this was part of the international AAP that Fred Sod presented at ASCO this year. And he looked at concomitant denosumab and radium, obviously not randomized, but it was a little bit interesting that those individuals who had received denosumab actually lived longer. And that was a little bit of a surprise, but actually it sort of mechanistically fits with some of the things we're thinking. And then we get back to Nick's issue about, what other drugs do we use? And they also looked in a non-randomized fashion, of course, about the combination of abiraterone and radium. And they also show overall survival was better. And this may have just been due to prognostic factors. We don't know. And obviously there's a large prospective trial ongoing now. But one of the other things, and almost it's an afterthought, but I need to say it, denosumab plus radium, completely safe. Abiraterone and enzalutamide plus radium, completely safe. There were no new safety signals from these novel combinations. But one of the things when it comes to sort of Abi and Enza, when we talk about concomitant, it doesn't tell us when it was actually utilized and when it should be utilized. Should we be using the combination at the start, or maybe when you sort of induce some sclerosis, the so-called flare, or maybe we ought to be consolidating at best response, or maybe we ought to do it at very early progression? Actually, I'm not sure that overt progression is the right timing, although that's kind of what we do clinically. So I'm just going to submit to you that I don't really know when these combinations might be optimally used, and I could provide a rationale for multiple time points along the continuum. This is the flare that we all know about, and this is an Abi-treated patient here who ends up with an enhanced bone scan. It looks like progression, of course, but it's not. What it is healing bone. Here you've got a relatively lytic lesion from this patient, and it's turning more blastic, so it takes up more technetium MDP, so the bone scan gets hotter. Well, do you want to give radium here, or do you want to give radium there? Well, that's a pretty obvious answer to me. We want to give radium when we have the target a little better induced. So the question really falls into the purview of doing proper clinical trials, and Abi plus or minus radium, Enza plus or minus radium, phase 3 is ongoing. One day we're going to know the answer. Safety of concomitant external beam. Just a little bit of a sidelight here. Dr. Finkelstein presented at ASCO GU, and I won't bore you with all the details, but the bottom line is you can give radium and you can give external beam at the same time. It really doesn't cause any harm. And then Mike Morris's abstract was mentioned a little bit, and basically what he looked at was some of the PSA and alk phos changes from baseline. And on the waterfall plots, this looks a little bit better with the combination right here, and the ALP declines look a little bit better. You can see the median percentage decline, -75, -55, -77, -59. So this looks good, but it was also a little bit interesting, and I'm not being a naysayer, but I do want to look at the safety data, and actually the safety data has not yet been presented. It was not presented at ASCO and not yet presented. Now, there's expanded access trials, and I showed you some of the results from Europe. I want to show you a little bit from USA as well. And this is one of the things that I presented at ASCO this year. And it struck me about this sort of duration of radium administration. And if you look at this, here the medians are not yet reached. This is a USA expanded access program. People like Nick Vogelsang were very involved with this, contributed a lot of patients. And you can see that if you only got 1 to 4 injections, that the median survival is only 7.5 months, which is pretty dreadful. Now, this doesn't say that if you get more radium, you live longer, because the truth is we analyzed it prognostically, and these patients who only got 1 to 4 injections had a number of poor prognostic variables, higher LDH, lower hemoglobin, higher alk phos, etc. So it could have simply been prognostic, but at the same time, this split was just almost more than what I thought the prognostic indicators would sort of explain. So saw this data. We actually went back to Alsimca. We had not analyzed Alsimca in this manner before. And here's the radium patients that received 1 to 4 versus 5 to 6 injections. You can see 17.9 versus 6.2 months here. But then I said, okay, wait, we got to get the placebo too. And then I was kind of surprised, and I presented this last night, about the difference in the placebo, and it's 15.8 versus 6.1. So goodness gracious, there's a strong element here of simply being well enough to receive multiple injections, and I think it gives us a real pause. Now, and I will point out that there was some 17.9 versus 15.8, so about 2 months better, and I'm not saying that these are comparable because you really have to do multivariate analysis. By the way, we've done multivariate analysis and unequivocally radium adds to survival, so we should dispel with that. But then we went back and looked at, so what sort of explains the survival differences? Well, one of the key things was the number of injections that you had actually received, and presented this at ESMO Echo in Vienna just a little bit ago. And you can see in the placebo group right here for Alsimca, 42% of the patients had 1 to 4 injections, as opposed to only 27 of the radium. And here, 5 to 6, obviously the inverse, 73 versus 58. So one of the things that's pretty clear is that to explain the overall survival benefit, a portion of that is taking these patients who would ordinarily perhaps have gotten 1 to 4 and be able to extend them into 5 or 6, indicating that radium was doing something relatively early on. And I think it also contributes if you get 6 or more. But these were an interesting series of analyses to me, and also underlined, when we go back just for a moment, 6.2 months, 6.1 months. There are a lot of patients who are being treated with radium who basically have about 6 months to live. Well, in my practice, as a general rule, and I'm not always good about following my own rules, but the last 6 months of a patient's life are probably better suited for hospice than they are for a lot of active therapies. So I think a lot of the patients who are getting radium in these trials and expanded access are really patients that are on the cusp of hospice because they're dead in 6 months and they're not getting their radium in an appropriate amount. So then we began to look at the predictors of 1 to 4 versus 5 or 6. And we looked at the EAP and we looked at the Alsimca as well, and unfortunately did not have LDH in the AP. But if radium was given as 3rd line or later, then that was a poor prognostic sign. ECOG performance status 2 or greater, well, of course that's bad. Hemoglobin's low, that's bad. Look at the LDH, hazard ratio, 12.9. When that LDH starts to climb, you might have missed the radium window. 12.9 on the hazard ratio, P less than 0.001, lots of zeros there. And the bottom line is that's probably the single most important prognostic factor. So watching that LDH does make a difference. Albumin, log PSA, and ECOG performance status. So if you want to be able to get your radium in, you probably don't want to be using it as 5th line therapy for patients with an LDH of 1,000. That's just not going to work very well, guys. So what about radiation immunotherapy? It was interesting, John raised a little bit earlier, about the importance of the host. And I think the host is very important. I don't actually have enough time to go into all the rationale, but actually there's a lot of rationale to think that the combination of radiation and immunotherapy could be quite productive. And there are actually radium and anti-PD-L1 studies that are very soon to be launched. I mean, those studies are all in the advanced discussion right now. So we're going to get this data. And in terms of the CYP, well, Emmanuel, I'm not sure where that is, but we're going to continue working. Upfront radium, won't talk about this much because Nick did. In front of the GU steering committee, actually approved by NCI, I think, most of us would agree today that ADT plus docetaxel is a standard of care. Can we add radium and do better? And I think it's a good question, and I think we need to be able to do it. But not everybody gets docetaxel. Some people refuse, some are ineligible. I think it's a good question to ask in radium add value there. So we have more to do in the hormone sensitive space, but it sure does make sense to look. So in summary, more studies of radium and imaging are required. I think that's pretty obvious. I actually believe, and it was done in Alsimca, it was always given with best standard of care. Radium was given the best standard of care in Alsimca, and I think it's always been intended to use in combination, so keep using it in combination. I think the agents have changed since Alsimca, and it's really very conceivable to use the best available hormones and the best available osteoclast inhibitors today. That's what I'm trying to do in my practice. Prospective studies are obviously justified. I think, I could be criticized for standing on a stage and saying, use combinations that have never been shown to provide a survival advantage. But I just cannot bring myself to use radium and ketoconazole or radium and nilutamide when we have better agents. I just can't do it for my patients. I think patients chosen to receive radium should have life expectancy that allows 5 to 6 cycles of treatment. Don't start radium for your patient who's about to go to hospice. I think studies of radium and various immune modulators are fully justified, and I think that studies in hormone-sensitive disease are fully justified. So thank you very much. Pleasure to be here. If there are any questions, I'll be happy to take them. Nick?
Oliver, do you know of any studies that have looked at radium with and without bisphosphonates, with bone alk phos, sort of intermediate endpoints?
No.
It seems,
we should be able to tease that out of Alsimca, and we haven't done that. It's a terrific analysis. Remember the stratification, an upfront stratification, right, plus or minus bisphosphonates. We could probably tease out the zoledronic acid, because I have a little bit of misgivings about looking at something that is not FDA approved. I mean, alliginate or whatever. But no, I like that analysis.
Well, I know that your data have convinced me, at least in a practice situation, to use bisphosphonates each time I give radium. So I just tell my patients, you're getting radium and bisphosphonates today. I don't know if that matters. So, and Tanya's point about the timing of the bisphosphonate is also curious, because there is a immediate and then a recovery. And how do you monitor that?
Yeah, so two things. Actually, as you know, I was very involved with the samarium trials early on, and so we actually looked at that question. It turns out that hydroxyapatite is basically non-saturable, and you can give the bisphosphonate immediately before, and it really doesn't change the binding characteristics of samarium. I cannot tell you about radium, but I would imagine it'd be the same. But, when you look at the pre-stratified analysis in Alsimca, which we published in Lancet Oncology, you look at that differential within the SSEs, it's really pretty striking. And in an independent multivariate analysis, both the radium and the bisphosphonates were found to be contributory toward improvement in SSEs, and together it looked even better. Yeah. Sorry, John.
It's interesting when you look at your, those who do well, those who do poor, but there is a group that looks like when you give radium that would have been in the group that do poor now do well.
Yeah.
So my question to you, how to identify, I know there's some clinical things, but that's the group that seems like the ones that you really have to catch early, because those are the ones that you may lose if you don't. So is there anything, again, even genomically or any other ways that you may be looking at to try to pick out that about 15-20% of people that if you don't hit them very early, they're going to be on that wrong curve?
Well, it was really interesting. I was almost laughing to myself when Nick was presenting his chemotherapy discussion. He says, well, I want to get them right before their LDH goes up and their hemoglobin goes down. And I think that's the right spot. You want to hit them right before then, for sure. John?
I think, but I could be wrong on this, have dose calculations actually been done in patients?
Yes.
In other words, I know for the whole patient they've been calculated, but I mean, has anybody actually gotten a biopsy and determined the actual delivered dose to the bone marrow?
It's highly dependent on the actual sclerotic and blastic phenomenon because you actually deliver a lot more dose to patients who have a lot of bone turnover. There have been some calculations done. They were done fairly early on. I'm sorry, I can't quote them. But the thing is that there's a lot of heterogeneity because of the stromal heterogeneity in these patients. You go from place to place in the bone, and sometimes you're looking at exuberant osteoblastic reactions. Another place, you're looking at clean bone, and it's vastly different in those two areas.
When we were thinking about combination trials at Hopkins, we actually got with our orthopedics people and also our pathology people, and it got into a big discussion about skinny needle biopsies of the bone wouldn't work. You'd actually want to do a real bone biopsy.
Yep.
Okay. And the nuclear medicine people were extremely excited about that because they claimed, I'm not a good reader of this literature, they claimed they could not find any data in the literature about actually dose delivery. And so what they wanted to do, they claimed they could do it if they could get the tissue very simply.
I think they should do it.
Right. And I was just wondering because, something works, okay, and then we can be pragmatic about it, but also just actually figuring out, just like we know with the pharmacogenomics, there could be big variations right within patients. So even though you're trying to get, I applaud you for the idea to try to get more cycles in, but again, the amount of dose per cycle could actually be a rate limiting step. So without these, you get to the point of saying you're making a patient go through it, so you don't want to make them suffer more, but then you're not using it intelligently. So it does get us back to the idea, when does a biopsy become mandatory as opposed to just a correlative study?
No, a great point. And, among the host variables that I think are important to remember all those DNA repair defects that we've learned about from the cell paper. And the bottom line is, I have one of these guys with a germline, BRCA2, 12 cycles of radium in, and he is doing unbelievably well. So radiation sensitization can occur from somatic or germline mutations in addition to potential things. And by the way, doesn't it sort of cry out for a PARP inhibitor along the way? It does to me.
So Oliver, I have a patient with BRCA2, he had a 90% PSA reduction with radium given alone, without any other concurrent therapy.
I think we have a series of 2, Emmanuel. Mine's a little different, but I think we should probably write up our series of 2. I wasn't aware of your patient.
Oliver, I just want to go back a minute at the risk of seeming dumb, except that Emmanuel and I both looked at each other and thought, oh my God, we give biphosphonates all the time and never think about when we're staging the patients. And all these phase 3 trials, they control for do they get them or not, but not when they're getting them in relation to their staging scan. So are we missing, are we doing it wrong?
Well, I think it's an interesting point because, it actually has not been studied very well, has it? And we practice a lot of faith-based medicine, but, I think we have the opportunity to learn more. And that would be a good study for a resident or maybe a med student, to go back and look. But it'd be a little bit difficult to do retrospectively because you'd have to control all the variables. So in essence, you'd have sort of a match pair analysis. But no, good point. All right. Hey.
Yep. So Oliver, great talk. Of course, the PARP radium trial is going to happen.
Yep.
It's being spearheaded by Kevin. So we'll hear a little bit more about that. But have you seen responses outside just your BRCA altered patient that you can attribute to a DNA repair alteration?
I don't know how to answer that because we've not been doing the directed biopsies. And as a consequence, the somatic alterations are not defined in our population. We do see PSA reductions in some patients, but I can simply say that great study, let's do more.
Okay, well, I think we'll find that out. Thanks.
Yeah, no, and I'm aware of I've had discussions with Kevin on that, and I think Kevin's going to allow Tulane to participate as well. So we'll hopefully put that forward as a good study, because the induction of DNA repair deficiency in combination with radiation makes perfect sense. All right, probably enough talking for me. Let me get on.